To this week's Grand Rounds. Just to introduce myself in case someone doesn't know me, I'm Lucia Agajinova. I'm Clinical Associate Professor in the REI Division. And it's my pleasure to introduce our colleague from Radiology Department. And I hope we are all ready to learn in this fresh and crispy morning. Dr. Priyanka Jha is Associate Professor of Radiology in the Body Imaging and MRI sections at Stanford University. She completed her diagnostic radiology residency from the University of California, Davis in 2014, followed by abdominal imaging ultrasound fellowship from UCSF in 2015. And then she served there as a faculty until 2022 when she moved to Stanford. Dr. Jha's research interests include gynecological imaging, pretty much everything about women's health, but she also focuses on ultrasound and MRI imaging for ovarian lesions and endometriosis, O-RADS classification system for adnexal lesions, MR applications of female pelvic and obstetric imaging, imaging needs of transgender patients, and medical education. She has authored more than 80 peer-reviewed publications, 40 book chapters, amazing, and has been invited to lecture nationally and internationally. She led the O-RADS steering committee working on updating O-RADS version 2022. And now that we see in our reports O-RADS classification, that's her doing. She also was a member of Society of Radiologists in Ultrasound Endometriosis Consensus Conference Committee, Society of Abdominal Radiologists Consensus for Endometriosis and Placenta Accreta Lexicon for Magnetic Resonance Imaging. As you can see, it is vital for us to work together with her, and I'm happy that we're finally all set here to learn today from Dr. Jha. So again, it's my pleasure to introduce you, Dr. Jha, and without further delay, please take the podium or the spotlight or screen.
Thank you so much for that kind introduction. It is just my honor to speak to your department today. Thank you, Dr. Shaw and the Grand Rounds Committee and your whole department for having me. I'm going to start my screen sharing now. Let's see. Okay, are you guys able to see my screen?
Yes.
Excellent. Okay. I wanted to share how we got to the topic of our discussion today. I was talking to a few of our colleagues who we have been in touch with regarding clinical care, and then Dr. Shaw, and I was interested in discussing some of the new updates in gynecologic imaging and how the imaging is trending for GYN and OB disorders. And in discussion with Dr. Shaw, she was like, we sometimes see a lot of indication for MRI, request for MRI in these reports. What about MRI? Why are we wanting to do MRI? So decided to go ahead and just include that in the discussion too. So we'll take a journey through different GYN disorders, and then we will include MRI as we go. I don't have any disclosures. So first of all, we want to talk about the complementary role of ultrasound and MRI. Now, ultrasound is a first-line imaging modality for the female pelvis, and as we go through our discussion, we'll figure out when MRI can be useful for benign gynecology. We'll be talking about endometriosis, gynecology, oncology, and then imaging during pregnancy. The MRIs could be used for both obstetric and non-obstetric indications, but for this discussion, we're going to focus mostly on placenta accreta. So ultrasound first, we can't really say this enough number of times, and that's what we notice in our practice too, that we do ultrasound the most, and it is the most appropriate way to begin our imaging for gynecologic patients. There are differences between MRI and ultrasound, and when I look at ultrasound, and I know that some of you do your own ultrasound in practice, so it is quite clear that it is like shining a torch. It allows us a focused evaluation, but we can really only look for things where we're looking for it. And ultrasound requires being really aware of what the pathology looks like, because you can sweep by really quick and miss it. Now, MRI is slightly different because it allows us a bird's eye view, and having a search pattern is really helpful. So it helps us identify where to look for things and what are we looking for. So moving on to this discussion, we talked about O-RADS, which is one of the most cutting-edge research happening in OB and GYN imaging. So we wanted to discuss why we want to do O-RADS. We had been doing imaging for ovarian lesions for as long as we can remember, but this is what our reports looked like. We were using the words indeterminate, heterogeneous, vascular, cyst, nodules, and perhaps the word that I've had this discussion with a few people before, complex. And we were using the word complex as sort of a blanket term to describe so many adnexal lesions. Now, the issue is that all of these terms are very non-specific. They have been used for both benign and malignant lesions, and when used as such, they provide us no information about the risk of malignancy, and they do not convey our suspicion as clinicians, as radiologists, or as gynecologists as to what do we think. Do we think that this lesion is malignant? Do we think that this lesion is benign? Our emotions are not well communicated with that. Now, with O-RADS, it was noticed that it's actually very good for most of us to be able to differentiate between an absolutely benign and an absolutely malignant lesion. But majority of the ovarian lesions were falling in this somewhat indeterminate category. And that's where O-RADS plugs in because it provides evidence-based risk stratification. It tells us what is the risk of malignancy for ovarian lesions. And we have used the data from Europe, from the IOTA group, to create O-RADS. And in IOTA, they have longitudinal data for patient follow-up over several years, greater than a decade. Now, O-RADS went above and beyond IOTA. This is a question that comes up, that if we ended up using IOTA data, what did O-RADS actually add? And what it did add was management strategies. Based on the data as well as expert consensus, management strategies were proposed that allowed for guidance on how to manage these lesions. Should we do further imaging, or is this lesion something that should be managed by gynecology, oncology? Where does this patient go next? And the goal was definitely not only to prevent extensive surgery for benign lesions, but we very well know that when the first surgery for a patient with malignancy is performed by a gynecology oncologist, then the patient outcomes are better. So there was benefit in both identifying benign and malignant processes with increased confidence. And with this, O-RADS was published in 2020 with an update that came up in 2022 because now additional validation studies were available from US centers as well. So I want to focus on how O-RADS is changing our practice. So the first thing is something that we talked about. The first change that we see is that now we're using standardized lexicon to describe these ovarian lesions, and we have appropriate triage and management guidelines. The lexicon really stresses on identifying what is physiologic, identifying the follicles and corpus luteum, which will happen only in premenopausal patients, which is very important. And then anything which is not a part of normal physiology of the ovary is considered non-physiologic. And we prefer the term lesion instead of describing mass because lots of benign benign processes can present as mass-like appearance as well. Once we have identified a lesion, there are some lesions which have a very characteristic appearance on ultrasound, and they are benign. So we have these classic benign lesions. And when I discuss this with our residents, I tell them that they're your three best friends. They are your three best friends because you're very familiar with their appearance. And when you see them, you can literally say, "Hi, hemorrhagic cyst. Hello, endometrioma. How are you, dermoid?" Because they are very characteristic in their appearance. Now, anything which does not meet a physiologic or a classic benign appearance is going to be a lesion, and this is what we call the great divide in O-RADS. And anything which is not in the first two categories has a plausible risk of being malignant. Now, we don't only classify lesions as malignant, but here we can see that we go through scores 1 through 5, and we describe what a normal ovary looks like, going to the highest risk of malignancy in an O-RADS ultrasound 5 category. And on the right side of this chart, we can see that we provide management recommendations, which are very simple as a follow-up with the benign lesions. And as we get higher and higher in the risk score, we see that we are now involving MRI, as well as our gynecology oncology colleagues are recommended to be involved. And this here is the great divide. So 1 and 2 are going to be your almost certainly benign lesions, with the risk of malignancy being less than 1% in any lesion that is scored as an O-RADS ultrasound 2. In real practice, when we look at our data, it is even lower. So it is really reassuring when something is scored as O-RADS 2 or lower. And greater than that, we are now dealing with a plausible risk of malignancy, which is highest in the O-RADS ultrasound 5 category. So we did this research. We wanted to see that IOTA is great, but how is O-RADS doing in the North American practice settings? And we found that O-RADS was performing, it was behaving as we thought it would behave. And once we have an O-RADS ultrasound 2 score, the risk of cancer is very low, which can be reassuring for both clinicians and patients alike. There are other studies that have looked at this as a study from Canada, and they're all coming to the same consensus that the O-RADS ultrasound stratification system is performing as we thought it will, with the malignancy risk ranges being appropriate. We talked about pattern recognition, O-RADS, and these are the appearances of what these classic benign lesions look like. Now, we have been asked that why did we need such specific descriptors? And this picture kind of says it all. So when we look at the lines in the center image on the dermoid, these are hyperechoic lines that is related to the keratin. They have this acoustically bright component from the fat in the dermoid. A similar appearance could be seen with hemorrhagic cysts, but the hyperechoic appearance is very characteristic for dermoid. So to allow for enhanced pattern recognition, we have some specific lexicon descriptors, such as the hyperechoic lines and dots for the dermoids. For the hemorrhagic cyst, I'm demonstrating a retractile clot appearance, and then for the endometrioma on the right, we have the sine qua non appearance of low-level ground glass echoes. So with this pattern recognition up our sleeves, we can really do a fantastic job identifying the benign lesions and avoid using terms such as complex, and which can scare patients. And they might just have a dermoid, but the term complex leaves a lot to their imagination and interpretation. Now, here's another example. This is a 49-year-old patient. She came with an abdominal fullness. I'm sharing some ultrasound images. And this is where ultrasound evaluation gets more involved. So while we're looking at it, we can see this large 10-centimeter lesion. And the bottom left image shows that not only it has these echoes, it has something that appears slightly more solid appearing in nature. So O-RADS has this app, and if you are using O-RADS in your practice, are interested in seeing how it behaves, then I think the app is a really great point. I almost say that if you've ever ordered Uber or DoorDash, you can learn O-RADS because there's a ton of good information here. So let's approach this lesion with this calculator. So let's touch this here and say this patient is premenopausal with an ovarian lesion. And this does not look like our physiologic findings, so it will be a lesion. And now we know what our three best friends look like, and we know that it's not looking strictly like one of our best friends. So we're going to call it a cystic lesion with a solid appearing component. And once we have made that selection, we note that there are no papillary projections or ascites. O-RADS recognizes that ascites could be a sign of malignancy or a higher grade malignancy in patients with ovarian cancer. So it accounts for an O-RADS 5 score. So here we say there was no ascites. And look, we already have the score. We have the O-RADS ultrasound score, the numeric risk range of malignancy, management recommendations. And if we were interested in, comparing it with what other lesions look like in this risk category, we can just click here and see other examples. So this was really a very helpful tool, which has helped us spread the awareness and bring O-RADS to a generalist, and anybody who's not even a gynecologic specialist can use this app and provide accurate stratification for these lesions. Now, this lesion went on to an MRI because it was an O-RADS 4, and this really, MRI really helped us troubleshoot this lesion, because when we looked at this MRI, I'm sharing some images, which the first set of images is without contrast, where we can see that the fluid signal is T2 bright, T2 slightly dark, and corresponding to the observations on ultrasound, we see something stuck at the back of this lesion. This is the most important area we want to evaluate with contrast enhancement, and especially for lesions which are bright by themselves, or what we call as intrinsically T1 hyperintense. We can perform subtraction images to look for absolute presence of enhancement and make sure it is not being masked by the intrinsic signal within the lesion. And fortunately for us and the patient, when we evaluated this area, there was absolutely no enhancement in this lesion. And that is really very reassuring. And we could downgrade this lesion to an O-RADS MRI-2. This lesion was surgically excised based on size and symptoms, and it was an endometrioma. So here, MRI plays a very beautiful role in showing whether the solid component is enhancing or not. On MRI, if there is one thing that drives the risk of malignancy, it is absolutely enhancing solid tissue. We are always carefully evaluating all of our lesions for solid tissue and trying to make sure that we are getting enhancement or not. And when we do get enhancement, we can use curves to further risk stratify as low, intermediate, or high risk of malignancy. So I've clubbed these together, changes 2 and 3. Now, O-RADS helps us because ultrasound-based assessment of ovarian lesions can guide us which lesions are going to benefit most from an MRI. And it is the presence of solid appearing components that really drives us to send patients for an MRI, because the cystic component can be well evaluated with ultrasound, but sometimes the solid component needs a little bit more advanced assessment with use of intravenous contrast. It also gives us a signal that for lesions which are within the 1 to 10% risk of malignancy, which are the O-RADS ultrasound 3 lesions, the risk of malignancy is low enough, and it is coming at the lower range of the validation study, so coming down to somewhere 2 to 5% based on the study you look at. And we recommend using ultrasound for the initial follow-up of O-RADS ultrasound 3 lesions. So here, the system has a little bit of a built-in cost effectiveness, where we can see that using ultrasound for the low-risk lesions and MRI for higher-risk lesions can be very helpful. So why is MRI helpful in addition to just looking for enhancement? Now, MRI has high sensitivity and specificity for both benign and malignant lesions. And similar to the O-RADS ultrasound, evidence-based risk stratification system was developed for MRI, and it was based on the ADNEX MR score, which was the basis for this lexicon. We see this lesion here. This is a solid lesion that was seen on ultrasound, and this came to MRI. But on our MRI here, I am sharing T2 and diffusion images, and we can see that this lesion has a very characteristic appearance. So if we were to describe this lesion, we may, on ultrasound or even on MRI, say that this is a solid appearing lesion. It appears to have some irregular margins. But what is really classic is the low signal. This is what we call with imaging T2 dark, diffusion dark lesions. And these lesions are pathognomonic of fibrous tissue. And this is where MRI can help us downgrade this lesion again to a benign category. This lesion 2 was excised and was found to be a fibroma. So in ultrasound, we were already doing an excellent job identifying the simple cysts and the hemorrhagic cyst endometriomas and dermoids. But with MRI, we add this further characteristic feature of T2 dark, diffusion dark lesions, which are also benign, and increasing the breadth of benign diagnosis that could be achieved with imaging, and these could be managed by a gynecologist. So the fourth change that we're seeing is that the O-RADS system is accessible to many imagers. So if we are seeing more and more of our reports mentioning the O-RADS score, it's just because the system is easy to use and interface, and there are many tools that are available for us. We shared what the app looked like, and the MRI also has an online calculator, and a web-based calculator is being developed for O-RADS ultrasound as we speak, so should be available for your use in a month or so. This is what the O-RADS MRI risk stratification looks like. And here again, we can see similar to the ultrasound, we have the risk of malignancies available along with the management pathways coming again in a few months. So mostly lesions will be seen with pelvic ultrasound or CT. MRI remains a problem-solving tool for definitive characterization. And we are seeing this enhanced specificity with MRI because MRI is the MRI system was validated on the European data. And it goes ahead to show benign markers, such as we can see detect fat with confidence with our fat detecting sequences. We already looked at this example of fibrous tissue. So now I want to show what fat looks like on MRI. And here we can see that on T2 weighted images and T1 weighted images, fat is going to be bright on both the sequences. But we can do the sequence design such that we can tell the magnet to stop producing any signal from fat within these lesions, and we can use fat suppression techniques. And when we see the corresponding drop off, almost similar to the abdominal fat, then we know that this lesion is a fat containing lesion. And sometimes dermoids can appear really bizarre on ultrasound, and having MRI establish the chemical presence of fat in this lesion is extremely helpful. So here's a lesion. We can see that it is bright on T1 and T2, but when we suppress the signal, it is dark, confirming the presence of fat in this lesion. And similarly, there's a larger component here which has like similar characteristics. So if we look at this region, it is bright, and then suppresses on fat, also confirming fat. And you can see just based on the sheer size and multiple locules of this lesion, these lesions can be challenging to diagnose just based on ultrasound, and MRI can aid with that diagnosis. And sometimes having these multiple compartments is helpful because lesions can present both a cystic and solid areas. So we evaluate all the possible areas. A question that often comes is that my patient cannot get contrast. Can we still get an MRI? And the answer is absolutely yes. We may not be able to give O-RADS score, but there is enough information available that we can triage the lesions broadly into benign versus malignant categories. And this study has shown that the initial triage that could be obtained, even with a non-contrast MRI, is quite helpful sometimes in lesions that remain indeterminate or incompletely characterized after an ultrasound. So with that discussion, I want to take a quick detour into benign gynecology. Well, you must be wondering, why am I sharing this example of fibroids? Because this patient came with acute abdominal pain. So they're one of the most common indications we see for MRI, for fibroid mapping and surgical planning. I think this is one of the most common studies I end up reading when I'm on the GYN service. And this example shows that when the uterus is so large, we can run into challenges with shadowing and severe disease, and the endometrium is obscured, so really have a hard time finding submucosal components of lesions. It's also sometimes challenging to distinguish between myomas and adenomyosis. So this is a classic appearance of a uterus which has multiple myomas. We see this characteristic low signal lesions. We are able to identify the endometrium. And you can see that when we are trying to look at this through the transabdominal approach, this fibroid is going to obscure endometrial visualization. From an endovaginal approach, the uterus is retroverted, and we know that sometimes it can be hard to line up the uterus in a way such that the endometrium could be adequately evaluated. Now, moving on, once we see the endometrium with MRI so much better, we are able to look for endometrial pathology in addition to these large fibroids that were identified. But this is an interesting example that happened here at Stanford. There's a patient who came to us with a concern for a cervical mass. And when we did the MRI for cervix staging, we saw that there was this interesting lesion. We saw the lesion, which was identified clinically. And once we saw this lesion and we compared it to what was coming up from north, we saw that there is a stalk that is extending from the myometrium, and this lesion was following the myometrial signal intensity on all sequences, and we were able to identify this mimicker, which was actually a prolapsing uterine myoma. And this was an interesting case that happened at my previous institution at UCSF. One of the surgeons called us in the reading room and said that this patient came with an outside read, and they said that they have huge fibroids, and I am having a hard time. Could you pull up the images and take another look? And we looked at the images, and sure, the uterus was enlarged and globular, but we don't see any of those T2 dark lesions that we saw in the examples we just shared. And what we indeed saw was this large globular uterus, which was diffusely involved by adenomyosis. Now, once we see adenomyosis, we're always interested in looking at what is going on in the posterior compartment behind the uterus. And we could clearly see that there was some thickening of the uterosacral ligament, and there was some bowel tethering to the back of the uterus, which brings us into the endometriosis category and makes us wonder, what is the other sites of disease in this patient. So here we can see that there is this hyperintense signal, and we can see how it will shadow completely when we were doing an ultrasound obscuring evaluation. And this is another example where ultrasound can be further complemented by performing an MRI, because the shadowing really puts a blinds on our eyes, and we can't really see at the deeper parts of the uterus. And MRI can help us distinguish adenomyosis from myomas. Just talking about the same, a different patient, adenomyosis can have different appearance. Sometimes we see this glandular predominant appearance. And sometimes when patients have been treated medically for their symptoms, we notice that the glands kind of disappear, and a more stromal predominant phenotype of adenomyosis can be identified. And this patient too had these endometriomas, as well as shown on the right image, that went along with this severe adenomyosis. And we've often noted that the greater the severity of adenomyosis, the greater the likelihood that we will find endometriomas or endometriosis in association in these patients. So we all know that endometriosis is presence of ectopic endometrial glands and stroma outside the endometrium. And this has been really a paradox of existence and detection, because it's a very highly prevalent disorder. We think about 10% of all premenopausal patients tend to have endometriosis, and definitely a much higher percentage in patients who have infertility or chronic pelvic pain. And it's a highly symptomatic disorder. But we have not been doing a great job finding it on imaging, especially on ultrasound. So we think about the types of endometriosis that we can see with imaging. We can see the ovarian endometrioma. We saw examples of it. We can also see deep endometriosis. We saw some examples of that with MRI. And superficial endometriosis is hard. It is much less commonly seen with imaging. And really, what imaging can do is focus on what is easily identified. This is sort of the low-hanging fruit that already exists in how we are imaging our patients. So we have these patients who are highly symptomatic with a highly prevalent disorder, and yet we have diagnostic delays of greater than 7 to 10 years with non-uniform detection of endometriosis and no real established lab markers. So we collaborated through the Society of Radiologists and Ultrasound, and it was clearly identified that this is an area of need for improving imaging detection of these lesions. Many of these patients will come from gynecology, but there will be others who would be coming from primary care. And like with most female pelvic pathology, they will get ultrasound is their very first test. And we can actually do something about increasing the detection of endometriosis on the very first test these patients get. So we focused on direct observations of endometriosis, which means that we're looking for endometriomas, the deep endometriosis implants in the rectouterine space, bowel invasive disease, urinary bladder disease. And I assure you, none of these images that I'm sharing were performed with a bowel prepared IDEA protocol involved ultrasound. All of these images are routine pelvic ultrasounds. I have personally never worked in a center where we performed a bowel prepared ultrasound, so I never had access to these images. But did we see endometriosis? Absolutely, yes. We have seen endometriosis on the routine pelvic ultrasounds, and from there, I'm sharing you these images. So we not only see the direct observations, we also see imaging evidence of the architectural distortion that happens with endometriosis. We have this sharply retroflex sigmoid-shaped uterus. We see the kissing ovaries. Both the ovaries are sitting behind the uterus in this unusual position, as well as we can see that there is bowel tethering posterior to the uterus, or the ovary may be retropositioned on only one side. And when we see these observations on ultrasound, we are inclined to recommend MRI because we want to see more. This is sort of casting a wider net. We have some screening criteria, of which we can think of endometriosis symptoms, or if the clinical indication says that, we are concerned about endometriosis in this patient, then once we see that, we can also perform a sliding sign in our practice. But more than the way the ultrasound is done, it's really looking for these observations and finding these patients who may benefit from additional imaging. So how do we do this? We really focus on the retrocervical space, which we consider as an endometriosis hotspot. And here we see this sharply retroflexed uterus. We can see that there's bowel tethering and there's a plaque right behind in that area, which is a deep endometriosis nodule. We can see the thickening of the uterosacral ligaments. But what is really striking, even to a person who is not a GYN expert, is that there is a bowel loop tethered to the back of the uterus right in the area of the implant. There's another example. We see the kissing ovaries here, and while we're sweeping through, we see that there is something stuck between the ovaries. And when we see these adhered, we want to really pay close attention to the area where the ovaries come together. We move on to an endovaginal exam, and we can see that we identify both the endometriomas, but in addition, we can see something that's peristalsing in between the two kissing ovaries, and there's bowel tethering right there. And when we actively push with a focused compression maneuver, all of this moves on block, and we see that there is dense adhesions in the posterior compartment. And this was the MRI correlate. We can see that there is the endometrioma, which is tethered to the back of the uterus, where there's a large serosal plaque infiltrating deep myometrium. Definitely solid endometrioma. And when we pay close attention to the back of the uterus, we can see this teardrop configuration of the bowel loop that signifies tethering to the back of the uterus. Once we see these large plaques, we're also going to sometimes see this clover leaf configuration of bowel loops. Again, all features of tethering and partial cul-de-sac obliteration. This was an interesting case. This was an obstetric ultrasound that was done, and they saw what they call a bladder lesion. They thought this was a bladder malignancy, and as all things happen in pregnancy, this lesion was quite vascular as well. When it came to for further evaluation, the clinicians chose to proceed with an MRI, and this is what we saw with the MRI. We saw a very T2 dark lesion, and if we have been following a theme, this is a benign marker. So we picked up the diffusion images. There were T2 dark, diffusion dark lesion, and we could clearly see that this is not a lesion that is coming from the bladder. In fact, we could see the hypertrophied mucosa right over this lesion. And we said, this is a process that is coming from outside in a female patient of reproductive age group. We think this is deep endometriosis, and nobody believed us. So they went ahead and did a cystoscopy, and there was no lesion to be found. So this is not an uncommon scenario where sometimes we have bladder endometriosis and a lesion is not detected on cystoscopy because this is an outside-in process, and the signal, sometimes we can even see glandular tissue in here, which further increases our diagnostic confidence. And once we see these lesions, we want to see how far they are from the urethral meatus and assess whether urethral reimplantation will be necessary for such lesions. Here are other examples of more severe urinary involvement where we see hydroureter, which is secondary to this large plaque that is happening. And usually we see this as extension of uterosacral and parametrial disease. And in addition, our MRI sequences are designed to look up at the kidneys. So if we miss the findings in the pelvis, it gives us a second opportunity to see if there is any explanation for hydronephrosis that we have identified on these lesions. We can also see bowel involvement. So this example has a patient who has an endometrioma, again located posterior to the uterus, and the bowel is attached to the back of the uterus in this broad-based fashion. As you can see, we're again focusing on the area posterior to the uterus. And when this patient went on to get an MRI, we were able to find this bowel invasive disease. Now, this is a very tricky concept because when we look at the European data, most of the people will say, well, ultrasound is really good for bowel disease. And here I'm sharing an example from MRI. And we have to remember that in Europe, the ultrasounds they do are bowel prepared ultrasounds, which are done by gynecologists themselves. So that does not translate perfectly well to our North American practice settings, where ultrasounds are mostly being performed in imaging. And yes, there are some that are being performed in gynecology where gynecologists are doing it. And the performance between the two ultrasound techniques is going to be different. So if we are following a conventional radiology-based pathway in North America, I think MRI is still doing better because our awareness for endometriosis is on the rise, but it is not at its peak yet. There is still work to be done. And as we saw in this example, we saw the broad-based bowel touching the back of the uterus, but this actual mushroom cap lesion, which signifies muscularis invasion. And here we can see that there is like near full thickness muscularis involvement, which may lead us to consider a partial discoid resection or other bowel surgeries, which were only seen best with MRI. So here's the lesion again. Moving on to some more gynecology, oncology applications, again, of working through the ovarian concept, we are really looking for these large solid enhancing components in lesions. And based on the presence of enhancing solid tissue, we can classify these lesions as malignant. Now we talk about ovarian staging, and I think this data that's coming out is really interesting. Last week I was at one of the radiology conferences. Maybe you had no radiologist at your tumor board. And what happens is that there's an MROC study and an Emerald study that was performed in UK. And what they're thinking is that MRI is actually doing slightly better even for staging of these patients. We need to wait and see how the whole data unfolds and what the publication comes through. But what they really said is that there were two things that they noticed. One was finding peritoneal disease. Interestingly, as we show in this example, that peritoneal nodules could be small, and we are looking for enhancement too. And they felt in their study that identifying these small peritoneal deposits was better with MRI. And very interestingly, they saw hepatic lesions better with MRI than they saw with CT. So that data is forthcoming, and we'll be definitely looking forward to it and seeing how does MRI play a role for staging ovarian lesions. So here's this large mass, unmistakably malignant. I'm going to go through these really quickly because I know that we are using it in our practice. So we use MRI for staging cervix cancer. It's really helpful to be aware of the zonal anatomy of the cervix to stage. And one of perhaps the most helpful roles for MRI is to find out who are the right candidates for trachelectomy. And MRI can be really helpful where we can do measurements and see if the patients would have functional residual cervix after a trachelectomy has been done. We can do a fantastic job looking for local regional extension of cervical cancer. Of course, we can see this large cervical cancer here. We can find it at even with a not so great MRI technique. But really what would change our management here is the presence of the subtle bowel invasion, which is so much better seen with MRI. And also, yes, we can identify invasion relative to the thirds of the vagina and see how far extensive the cervix cancer goes. So here's an example where we see the tumor, and we can see that the tumor is extending to the upper third of the vagina. We see the signal alterations on T2 as well as on post-contrast sequences. And again, MRI does a great job staging cervix cancer. For primary endometrial masses with the new FIGO 2023, we are perhaps again, the greatest role for MRI lies in fertility preservation and finding presence or absence of myometrial invasion. Conventionally, endometrial lesions will be hypointense to the endometrium. The endometrium is really bright, and these lesions are going to restrict diffusion. And while this whole area of reduced diffusion tells us there's malignancy, our interest is really in this smaller diffusion restricting nodule that is going towards the posterior myometrium, which tells us that there is myometrial invasion. And once we do contrast enhanced images, we can clearly see that this lesion is again invading the myometrium. So we will use the myometrial invasion is not a part of the staging for the percentage is not so relevant for staging anymore, but it's helpful to know that something that we learned from the old FIGO was really curious, and I still use this in clinical practice. So when we have less than 50% involvement of the myometrium, the chances of nodal metastases is lower. But if we have greater than 50% involvement of the myometrium, the chances of nodal metastases really jumps up. And how we use this in our practice is if we see a lesion which is invading the myometrium and we did not find nodal metastases, we go and look again. The risk of nodal metastases is so high that I almost teach to our trainees that if there is more than 50% myometrial invasion and we didn't find nodal metastases, chances are we missed it and we should go back and look for them again. So not relevant to FIGO staging, but still an interesting teaching anecdote that we share. And here's another patient who wanted to have fertility preservation, but we see the large endometrial lesion. Again, there is a concern for myometrial invasion, and that precludes her from having a fertility preserving treatment. Having done that, I want to spend the last few moments talking about obstetric MRI. I don't do very much of these cases anymore because they're housed in pediatric radiology, but time to time, there'll be an interesting case and somebody will gratefully share that with me. So I'd really enjoy looking at that. And this was something that we did quite a bit in my previous job. So definitely we are seeing a larger number of invasive placenta cases, and the increased frequency of cesarean section and the late age of delivery is all driving the risk for increased placenta accreta spectrum with many complications that can ensue, especially if the diagnosis remains unknown till the time of delivery. Just like everything else we have talked about, the ultrasound features of placenta accreta are very striking, where we see these loss of placental myometrial interface, we see these lacunes and these large tortuous vessels, and I believe that this is just an effort of the placenta to try and get more vascularity, because when it gets implanted in that fibrotic tissue, it really has to figure out how to best serve the nutritional needs of the fetus. So we did an ultrasound for this patient, and we were concerned about placenta accreta. This is a publication we did a couple of years ago on the MRI lexicon for placenta accreta, and I think this has really helped us streamline yet another challenging imaging diagnosis. We created this compendium of images to guide other readers. And here's an MRI example from the patient I shared the ultrasound for. So here we can see M shows the myometrium, P shows the placenta, and right where the placenta is, we see that the myometrium is thinned, and now we're losing that interface. And in addition, we see that there are these large tortuous vessels in this area. We can clearly see that the placenta is invading into the myometrium, and this would be concerning for increta, or what is now called as myoinvasive paths, as we try to move away from the accreta, increta, percreta nomenclature, with some centers even challenging whether true percreta even exists. Here is a great utility of MRI. In addition to ultrasound for doing paths. So here we see that there's like this normal thickness myometrium, and it gets thinner and thinner as we go down into this area of this wide-based placental bulge. And perhaps this was one of the most concerning features we see on MRI. We definitely can see it with ultrasound too. But what we observe is this deviation of the uterine serosa and outer contour presenting as this bulge, which is suggestive not only of increased severity of PAS, but of myoinvasive placenta creta disorder. And the latest research is showing that when we see this bulge, it essentially tells us that the only thing that's left covering the placenta is the serosa. And when we make these observations, we are concerned for full thickness myometrial replacement. Ultrasound is again an excellent first imaging modality. It's really like the most important modality, even more important than MRI, I would say, because if we don't make these observations on ultrasound, these patients are never getting any further advanced imaging or follow-up. So making the observation correctly on ultrasound is so helpful. We specifically wanted to spend some time and look at the placental bulge sign, which can be seen with both ultrasound and MRI. But on with imagers, we noticed that there was a slight ease of detection with MRI, which may allow for better characterization and appropriate staging for the severity of PAS. Intraoperatively, if you have seen an hourglass sign, we think that it is a correlate for that. We see the uterus that was removed after the hysterectomy, and we can see this H-shaped or the bulge again noted in the inferior part of the uterus. There was something that we changed at how we did pathology for these lesions. You know, when we were trying to do the conventional vertical sections, our anatomy was being distorted in some ways such that our correlations were not working out as well as we would like. So instead of doing that, we started doing these horizontal sections in collaboration with pathology. And here we saw that the correlation with the imaging, with the intraoperative observations was just excellent. And we really enjoyed seeing the patient as a whole moving through clinical and imaging workup and successfully being delivered safely with good outcomes. So MRI can help us guide our pathways in two ways. And I think it has more value in a positive predictive fashion, such that if once we detect myoinvasive PAS, we know that these patients are more likely candidates to have non-conservative management. And if there is an increased risk of bleeding, other hemostatic maneuvers could be considered beforehand. In addition to just the diagnosis, this was a patient who came to us for repeated bleeding with PAS. We were not seeing any frank abruption with ultrasound, but when we did an MRI, we saw this subplacental hematoma in an area of placental thinning, which is actually quite common. The placenta does tend to thin over the region of the cervix, and small amounts of hemorrhage could be better seen with MRI. And it's important to know that this can influence the time when the patient will be delivered, and this patient had to be delivered early because the bleeding was not subsiding. So here's another example where we see this patient, 5 previous cesarean sections and placenta creta, and we saw classic features of MRI. We even saw the bulge. So we're like, okay, what is MRI even adding to ultrasound? We have seen everything that we needed to see. But we had a very interesting observation here because in addition to the bulge, we were paying close attention to the vessels. And on the right side particularly, the placenta was really causing mass effect on these vessels, and we saw this large venous varix. So when we notice these features, it's really great to share this with our colleagues because they are well aware of a hemostatic risk. And this patient, while she was being delivered, she ended up having a situation where one of her vessels were injured, and we saw this large active extravasation and interventional radiology procedures, and she was having massive hemorrhage, and eventually a multidisciplinary team needed to be involved, and vascular surgery was involved with the repair. But the beauty of doing this, knowing this preoperatively, was we had already discussed this case. The vascular surgeons were available for a backup, and we were able to successfully take care of the patient. So MRI can, in addition to telling the severity, provide markers that can predict hemorrhagic risk in addition to presence and severity of the disorder. And then this is another interesting situation after which we're going to conclude our discussion is this is an early pregnancy, and we noted that this gestational sac is located immediately adjacent to the probe. Where is the myometrium here? And this was diagnosed as a cesarean section ectopic pregnancy. And even at the 12-week ultrasound, we were noticing that the placenta looked more heterogeneous and some abnormal vascularity was seen. Now, this was a highly desired pregnancy, and they chose to have an MRI, which, by the way, is safe. We can do MRI at both 1.5 and 3 Tesla. The American College of Radiology gives us a green light, and we saw other features suggestive of myoinvasive path in this patient. So for take-home points, ultrasound remains the first modality of choice of imaging. We did a whirlwind tour through the female pelvis, shared some guidelines where MRI can play as a role for troubleshooting, tissue characterization, staging, and there are probably thousands of other indications where we want to discuss how to best use the imaging modalities we have at hand. And I remain open, and I'm sure all of my radiology colleagues will be really excited to discuss this more with everybody here. So with that, I'm going to thank you for your attention, take any questions you have, and I want to express my gratitude as well as on behalf of my body imaging and Department of Radiology that we get to talk to you today and share how we can increase the collaborations between the two departments. Thank you so much.
Thank you so much, Priya. This was amazing. I feel just so much safer by having you there over at Radiology. We have a few questions in the Q&A section, and the first question is from Dr. Cohen. How good is imaging at differentiating benign from malignant teratoma?
Oh, that is a very interesting question. And I talked a lot about it in terms of ultrasound and MRI. And we are going to focus our MRI evaluation on looking for solid enhancing tissue. There is some research which is going on because we really don't know how much solid enhancing tissue is good versus like too much, but solid enhancing tissue really concerns us for looking for a malignant or an immature teratoma. What is really interesting is that CT can be very good for this diagnosis because uh, there's a very characteristic appearance of immature teratomas. We see these small islands of fat, and we see calcifications in the center of it. That can be hard to see with MRI because calcifications are harder to see with MRI. So if you have clinical concerns for an immature teratoma, consider getting a CT because it has a very characteristic appearance that can be seen very well with CT with calcification within small islands of fat. It's really a very sine qua non appearance, yes.
Is it something that, MRI imaging can suggest? Sometimes, radiologists suggest, recommend this or consider this. Would you guys suggest it if you think maybe that would be helpful to discuss?
Absolutely, yes. So with contrast, with the non-contrast part of our evaluation, we are able to see the fat within the lesions. And then with the contrast enhanced portion of the evaluation, we are able to see enhancement. And enhancement is never good news for ovarian lesions. So once we see that, we can raise the concern for malignancy. We could apply O-RADS for this, and most immature teratomas will fall in the O-RADS MRI4 category.
Thank you. I have a comment from June Obedin Malivar sending a huge thank you for just a comprehensive and compassionate conversation. So I agree with that. We have another kind of comment. Thank you for a wonderful overview of MRI. It is important to know that there are publications identifying that MRI may lead providers to the wrong diagnosis when ultrasound identified the correct diagnosis.
Yes,
Comment on that?
This can happen. It has happened, and there's truly nothing we can do to stop it. And it really depends upon the expertise which is available at the institutions. I am particularly aware of a publication with MRI in placenta creta, which talked about this, and it has come up in numerous radiology discussions before. And That's not been our experience. We feel, as I shared with my examples, that MRI can add and will add value. And sometimes, I heard somebody else say this, and I think I'm going to quote my colleague from radiology. They said it's like driving a car. You can give a person a car, but there is no way you can assume that they will drive it correctly all the time. And yes, it happens. And when MRI or pretty much any study is performed by non-experts, there is a chance for error. Perhaps there's a chance even for pitfalls in with error experts performing this. But I would say that in our hands, I think MRI performs well, and its judicious use could definitely contribute to the right diagnoses. And if there are other publications that you're aware of, send them my way because I'm really curious to see what leads to this. And for the particular placenta thing, I think the MRIs they looked at were performed in the early 2000s, and our MRI technique is so much better now. It is just not fair to use 2000s MRI as a reference standard for the MRI that we do in 2025.
Yeah, this is a good point. And I kind of wanted to go back to what you said and to endometriosis. So now, we are really using endometriosis to help, MRI to help us with diagnosis of endometriosis. So in your opinion, first, how well developed is that, right? I know Stanford, UCSF, MRIs give this conclusion and evaluate for endometriosis, especially if we ask for this. Can we rely on MRI results from other centers to reliably identify endometriosis? And in general, how reliable is it?
Yeah, that is a challenging question to answer because we can address the practices that we are familiar with. So we're familiar with the MRI performance at Stanford, and I know that we have a great collaboration with our mixed team here. So I know that we do a great job. And we have a great feedback mechanism. When we don't do a good job, we hear about it, and it's a growth opportunity to see what led to our interpretation and how can we actually enhance this detection going forward. What happens at an outside center is hard to predict. uh, I do know that if we have studies that we have overread from outside centers, sometimes we find additional sites of disease. Sometimes we think that what they're calling endometriosis may not be endometriosis. So I've seen interpretations change both ways. Um, it really depends upon who is the reader of the study, and they are going to really be the QA for the quality of the study that was performed and read. So we have a recent research publication coming out that we looked at all the cases where we called MRI was negative, and there was endometriosis seen on MRI. And we went back and looked at the cases, and the number one cause for a misdiagnosis of endometriosis on MRI was inappropriate technique or non-endometriosis protocoled MRIs. So we know that technique plays a role, and of course, the person who's interpreting the study also plays a role.
So there are ways to grow and develop as a field still, right? I mean, that's what
Absolutely.
yeah.
Absolutely.
I have one more question here. Do we know if it is cost effective to do the MRI in addition to the ultrasound?
It depends upon the indication. I guess for the indications we shared, for benign versus malignant indications, yes, MRI will be cost effective. For endometriosis, in our current practice, I would say 100%, because we don't do the bowel prepared ultrasound, and we will find additional sites of disease the more MRI we do. And this is our practice. Like, I have seen that once we have started recommending MRIs based on the ultrasound, and pretty much all of these have confirmed the diagnosis of MRI and have found additional sites of disease which are either inaccessible or incompletely evaluated with ultrasound. So those are just some examples that I can think of. But yes, there's no data that I'm aware of that is looking at cost effectiveness right now. I know that we're looking at some prospective studies, but we don't have that data just yet.
Yeah. And I have one more question. I know we have to finish. So just last question. Very interesting talk from someone who didn't put a name. When you say that MRI has much better sensitivity and specificity than ultrasound, what is reference standard and is it applied equally in all cases?
Yes, again, it depends upon the pathology. I think I said this in terms of ovarian lesions, that MRI has the greater sensitivity and specificity for both benign and malignant lesions. And the reference standard here are either surgical pathology, which is the most common reference standards that we use in radiology research, or we have for physiologic lesions, we have a resolution of findings on subsequent imaging, or characteristic imaging features on a subsequent imaging modality. For example, dermoid, which was confirmed either with FAT on CT or with MRI. So those are some of the reference standards we use. There is a paper, I didn't discuss it during the discussion, but specifically talking about how we looked at all the patients from 6 institutions that were operated between 2010 and 2015. And if we apply O-RADS to these patients, we may have precluded surgery in nearly 33% of those patients. So 1/3 of those patients, majority of who ended up having physiologic cysts or hemorrhagic cysts. So in these circumstances, I guess the answers could be had with the follow-up ultrasound. And the O-RADS reflects that. 2 and 3, we recommend going with ultrasound for even as a follow-up modality. And yes, there's definite benefit for MRI and higher risk scores. Also to know that when we have the high risk scores, we still don't have like 100% positive predictive value just with ultrasound alone or even with MRI. And that's why MRI can help us guide ourselves in the right direction.
And just one more comment from Lisa Rogogupta, excellent talk, and so wonderful to have increasingly accurate diagnostic imaging options for our patients. So we do have to conclude. I'm very grateful for your time, Dr. Jha, and we will work together and stay in touch. We will stay in touch. Thank you very much.
Thank you so much. And thank you for having me and sharing your morning with me. I really appreciate it.
Absolutely. Bye. Great day, everyone.